Okay, so a little review. Last meeting class, we continued our discussion about antihypertensive agents. So, ano yung mga natapos natin last time? Let's check. Let's check a little bit. We discussed about our beta blockers. Remember, their action is antagonistic on the most of the time it's beta 1 receptor, pero we have other drugs kasi that are non-selective, so they can also antagonize the beta 2 receptor. That is the reason why we use them with caution sa patients with COPD and asthma. So the most important thing that you need to know is the classification, whether they are cardioselective, meaning they only antagonize beta 1 receptors, but and pala, we have non-selective beta receptor blockers also, including propranolol here, so please add that. And we have partial agonists. They are actually antagonists, however, they have the ability to slightly activate the beta 1 receptor. So slight lang yung action nila. They are antagonists, pero they can slightly na activate our beta 1 receptor. So we have 3, the pindolol, acebutolol, and penbutolol. And ito yung mga mixed acting beta blockers natin. Aside from antagonizing the beta 1 receptor, they can also inhibit alpha receptor, specifically the alpha 1 receptor. So you can identify them quickly since they don't really end with olol, well, except for nebivolol. Okay, so yun yung diniscuss natin last time. And we also had our discussions about vasodilators. We classify them either orally or parenterally given. So definitely for maintenance purposes, we use the oral drugs, and for emergency cases, we use the parenteral ones. So I ended here sa phenoldiazepam last time. We will continue with our calcium channel blockers. They are still included in the vasodilators. However, we separate them because they have different mechanism of action among the other vasodilators that we have. Now, from the name itself, calcium channel blockers, they block the calcium channel para ang mangyari class, hindi na makakapasok si calcium inside the cells. Inside the cells in particular of the blood vessels. So remember, the blood vessels are also considered as a muscles, and yes, nagko-contract din sila. So when they contract, we are expecting na there will be constriction. Kasi since nag-contract yung muscle, liliit yung dadaanan ng blood natin. Okay, so before they contract, just like other muscles in the body, they also need the help of our calcium. So yung calcium is the ion class. Again, one of the ions that will help in the contraction of the muscle. So for us not to have the contraction, we will inhibit the influx of calcium inside the cell para hindi sila makapag-take ng action nila. Now, you will identify these calcium channel blockers through their names. Most of them end with dipins. Except for 2, we have verapamil and diltiazem. The rest end with dipin. So take note also of their brand names. And you are now having your duty sa community, and most likely you will be encountering these drugs, especially the amlodipine. Marami yan sa community, and isa yan siya sa mga antihypertensive agents na very commonly used sa community. So aside from amlodipine, yung dalawang drugs na hindi nag-e-end sa dipine, we have the verapamil and diltiazem. Then the other drugs that end with dipine, we have drugs like felodipine, isradipine, nicardipine, nifedipine is also very common, and we also have nislo dipine. So some of them are given orally lang, but meron din tayong binibigay parenterally. So example, the nicardipine. We have an ampule for this. Diba? We have the cardipine, which is actually expensive. And this is a newer member of the group, the clevidipine, though it ends with dipine pa rin. Pero unlike other drugs, this is only administered intravenously, the clevidipine. So again, kasama pa rin siya sa calcium channel blockers natin. Now, how do we classify our calcium channel blockers? We classify them according to their structure. Okay? Okay, sige, Jay. Again, we classify them according to their structure. If their structure contains the dihydropyridine ring, yun yung mga nag-e-end sa dipines. So itong dalawa, again, their structure do not really contain the dihydropyridine ring. So we call them non-dihydropyridine. They don't end with dipines. We have diltiazem and verapamil. Again, the rest class na merong dihydropyridine ring, ito yung mga dipines natin. Now, what's the clinical application of our calcium channel blockers? Syempre, we use them for hypertension. Again, how do they take their action? They block the influx of calcium inside the cell so that there will no be contraction of the muscles and there will no be constriction. Pag walang constriction, walang increase in the blood pressure. There will only be relaxation of the blood vessels. And aside from that, we will also encounter these drugs when we discuss anti-angina drugs, since this is also anti-angina and also anti-arrhythmic agents. Okay, we will have I think what chapter is this? Mga chapter 20 or 21. 20 ang angina, 21 at ang arrhythmia. So we will be having our discussion about these conditions also and the drug that we use. However, yung mga drugs class for these conditions are actually discussed already in the antihypertensive agents kasi most of the time parehas lang yung kanilang mga gamot. Meron lang mga dagdag, konti lang naman siya. Now again, inuulit-ulit ko ito. Mechanism of action of our calcium channel blockers, they inhibit calcium influx, pagpasok ng calcium inside the cells. So especially the cells of the arteries, the blood vessels. And take note that these blood vessels are also considered as muscles. Okay, so they also contract. Okay, now let's talk about dihydropyridines. Remember, when you say dihydropyridines, if they contain this ring, these are the drugs that end with dipine, just like amlodipine. Now, how is this classification different from the non-dihydropyridines aside from their names ending with dipines? Itong mga dipines class, they are selective. Most of their action is selective on the blood vessels. Okay? Again, they block calcium influx sa blood vessels. So that is the reason why the dihydropyridines, these drugs that end with dipine, are more used in hypertension than in arrhythmia or in angina. Kasi kung arrhythmia and angina, di ba? Angina is chest pain, arrhythmia is irregular heartbeat, okay, irregular na heart rate. So again, yung mga dipines natin, they are more of vasodilators since they inhibit calcium influx in the blood vessels, and that is the reason why they are commonly used in hypertension. They have less activity in the cardiac muscles, in the heart muscles mismo, they have less activity. So, hindi sila masyadong ginagamit for conditions in the heart. Unlike the non-dihydropyridines, yung verapamil and diltiazem, ito yung mas effective in the inhibition of calcium influx in the heart muscles or in the cardiac muscles. So, we will be using these two for heart conditions, again, like angina or arrhythmia. Now, among the two, verapamil class has the greatest depressant activity in the heart. So anong ibig sabihin nun? Verapamil and diltiazem will still inhibit calcium influx but in the heart muscle. So, syempre, yung heart nagko-contract yan. And since it is a muscle, kailangan niya din ng calcium para mag-contract siya. Now, i-inhibit natin yung calcium. So, ano mangyayari? There will be less contraction, there will be less beating of the heart, so there will be decrease in the heart rate, and that will in turn decrease the cardiac output. So, konti na lang yung mapapump na blood ng heart kasi nga hihina siya. Hihina yung muscles niya because of the inhibition of the calcium influx. So again, among the two, verapamil has the greatest depressant action sa heart while diltiazem has only intermediate action. So again, these two is they are used for heart conditions like angina or arrhythmia, while the dihydropyridines, but our dipines class are more commonly used for hypertension since they are vasodilators. They have their effect in the blood vessels. Okay, do you have questions about our calcium channel blockers? Baka may gusto kayong itanong about our dipines? Especially amlodipine, yan yung pinaka ginagamit sa market. Isa yan siya sa mga drug na gina-prescribe sa mga silingan. Kanang high blood ka, ana. Ako nag-take ko, most of the time they actually buy Neoblock. So, Neoblock ang pinaka-common. It's not the si Neoblock is not the innovator drug for our amlodipine. It's the Norvas. Kaya lang medyo mahal kasi si Norvas, di ba? So, yun yung pinaka-commonly na ginagamit nila, yung Neoblock. Manilang prescribe sa mga silingan. Okay? Questions? Before tayo mag-end. And ito na yung last antihypertensive agents natin. Inhibitors of angiotensin. We have 3 types of drugs na yung kanilang mechanism of action involves the angiotensin. We have the ACE inhibitors, the angiotensin converting enzyme inhibitors. Their names, we can identify them in the endings of their names. They end with prils like captopril. Okay, enalapril, and so on. And then we have also, aside from ACE inhibitors, we have the ARBs or the angiotensin receptor blockers. So their names naman end with sartan. And we have the renin inhibitor, which is not really common, but yes, its action is still on the angiotensin pathway. We have the aliskiren. So I'll be illustrating the pathway. We have a pathway for this. My problem is I forgot my pen. Nahirapan ako sulat sa screen, but I'll still try. Mag-type na lang siguro ako, and then let's just draw arrow later. Okay? Type ko na lang muna siya. Stimuli. Bro, ako na magsulat. Wait lang. Ay, na-delete. Wait lang ha, ulit. Kahirap na walang pen. Okay. Sige. Let's discuss this pathway. Ito yung renin and angiotensin aldosterone system. We call this, by the way, as RAAS. So if you are asked what RAAS means renin, angiotensin aldosterone system. This one is in the kidneys. So ito yung nagre-regulate ng blood pressure na in long term, long term. Kasi yung ating moment by moment, it's the postural barrier reflex. This time, it's the kidneys. It's the work of the kidneys. Now, itong pathway na ito, renin-angiotensin aldosterone system, starts with a stimulus or a stimuli, if marami. Example, if you are experiencing decrease in the blood pressure, again, if you are experiencing decrease in the blood pressure, let's simply put it as hypotension, okay? And aside from that, you have low sodium in the body or you have hypovolemia, meaning baba yung water mo sa body, and that will result to decrease in the blood volume. Yun yung mga examples ng stimuli, okay, that will trigger the action of this RAAS, this pathway. Pag na-experience mo yan, against low sodium is hyponatremia, ha? That will trigger the kidneys to react. And ano yung magiging reaction ng kidneys? The kidneys will release this enzyme. This is actually considered as an enzyme. Again, we call that the renin. So si renin, mare-release yan siya ng kidneys in response to the stimuli I have enumerated a while ago. Now, ano yung magiging action ni renin pag na-produce na siya ng kidneys? That will become an enzyme that will help the conversion of this substance, angiotensinogen. Again, si angiotensinogen will be converted into angiotensin 1, again, through the help of the enzyme called renin, which is released in the kidneys. So, by the way, si angiotensinogen is produced naman by the liver. Okay, it's a substance produced by the liver and it is actually not active. This is inactive. inactive na substance. So medyo wala siyang work. Kailangan niyo munang i-convert to angiotensinogen before magkakaroon siya ng action in the body. Now, itong si angiotensin 1, meron siyang kanyang receptor in the body, and if this one activates its own receptor, magkakaroon sila ng interaction, angiotensin 1 can cause vasodilation. So in the case na there is low blood pressure or hypotension, this is not actually good. Kasi mas bababa yung blood pressure ng patient. So anong gagawin ng body? Angiotensin 1 will be converted into angiotensin 2. And what enzyme is responsible in the conversion? It's BACE. ACE is angiotensin converting enzyme. Ito na yung tinatawag natin na ACE. So I hope by now, alam niyo na kung ano yung activity ng enzyme na yan. Again, we call that angiotensin converting enzyme. It's responsible in the conversion of angiotensin 1 to angiotensin 2. Now, if you have the angiotensin 2, meron din siyang sariling receptor in the body. Okay? So, once this angiotensin 2 binds to its receptor, we just call it angiotensin 2 receptor. Ganun lang yung tawag sa kanya. Ang action nito in the blood vessel, meron siyang direct effect on the blood vessel, and that will lead to vasoconstriction. So, yung first na stimulus, which is the low blood pressure, na-combat na siya. Kasi because of the vasoconstriction, remember, there will be increase in the blood pressure. Now, aside from that, the presence of angiotensin 2 will trigger the adrenal medulla to release a lot of aldosterone. Okay, so this is a mineralocorticoid which is responsible in the retention of sodium and water in the body. Okay, so that's how our body react to stimulus or to stimuli pag marami. So again, the presence of a lot of aldosterone in the body will cause retention. Maiiwan si sodium and si water in the body. Mare-regulate yung excretion, especially via the urine. So that will cure now the sodium na pagbaba ng sodium and ang water in the body. Again, we call this the RAAS, renin-angiotensin-aldosterone system. It's a system in the body that will happen due to stimuli like this one. Trabaho ito, class, ng kidneys. Okay? Kasi magsa-start lahat sa pag-release ng renin from the kidneys. Do you have questions about the RAAS? I really need you to know this heartily, yung RAAS na ito. Dapat memorize natin anong nangyari sa body natin. Walang questions. Busy sa drug test. Okay. Now, how about for patients with hypertension? If the patient has hypertension, so definitely we don't like the RAS to happen. Okay, but take place talaga siya sa body, no? Meron talaga tayong mare-release na renin kahit walang masyadong stimulus kasi this is endogenous. Makikita talaga natin siya sa body. And then meron talaga tayong angiotensinogen, mako-convert din siya sa angiotensin 1 and angiotensin 2. So dito papasok, class, yung anti-hypertensive agents natin. Kasi nga again, vasoconstriction will lead to increase in the blood pressure, and then yung increased aldosterone will lead to the retention of sodium and water in the body, which will in turn lead to increase in the blood pressure. So there are parts in this system that will inhibited by the drugs we have identified a while ago. Okay? Ano yung ginaproduce sa liver? Ito yon, angiotensinogen, si renin sa kidneys. Okay? So let's identify on which part of the system yung mga drugs nagtitake ng action. So yung first one na na-identify natin, dito muna tayo. Lagyan ko siya ng ganito ha. Kapag merong negative sign, it means it's an inhibitor. So yung isang drug which is not really common, hindi siya masyadong ginagamit sa market, we have the aliskiren. Okay? So aliskiren class is a renin inhibitor. If the kidneys produce renin, it will inhibit renin para hindi siya magkaroon ng action converting angiotensinogen to angiotensin 1. So definitely hanggang renin lang talaga siya, renin will be inhibited. Production of renin will be inhibited. So yung mga succeeding parts of the system will not happen also. And there will be no increase in the blood pressure. Kasi walang nabuong angiotensin 2, there is no vasoconstriction, there is no retention of water and sodium. So dito pa lang, sa start ng system pa lang, magte-take na ng action si aliskiren. Now, ano yung other two drugs na very commonly used in the market as a drug as a treatment of hypertension? The first one, yung mga nag-end sa pril. So dito yan siya. Lagay natin si ACE-I dito. Okay. Lagay ko ha, ACE-I. What do you mean by ACE-I? Angiotensin converting enzyme inhibitors. These are drugs na nag-end sa pril. Okay, lahat ng nag-end sa pril ha. So, yung pinaka-common among them, syempre si captopril. Captopril, enalapril, fosinopril, ramipril. All of them are ACE inhibitors. Now, from the name itself, they will inhibit this enzyme, angiotensin converting enzyme. What will happen if we inhibit this enzyme? Angiotensin 1 will not be converted into angiotensin 2. So wala tayong ganito class. Wala tayong angiotensin 2. We will have angiotensin 1, and remember, angiotensin 1 has a direct activity in the blood vessel. It has the ability to dilate the blood vessels. And remember, if we dilate the blood vessels, it will lead to decrease in the blood pressure. Okay, therefore, ACE inhibitor is really a good one to treat an hypertension. What's the last drug na na-identify natin that acts on this system? Yun yung ARBs. Okay, si ARBs. So dito yan siya ha, si ARBs. Anong ending ng ating ARBs? We have the sartan. Okay. What is the most common ARBs? Yes, tama yan siya. Losartan. Though aside from losartan, we also have valsartan, telmisartan, olmesartan. Lahat sila ay included sa ARBs. Anong meaning ng ARBs? Angiotensin receptor blocker. What do you mean by that? These drugs inhibit the binding of angiotensin 2 to its receptor. So definitely angiotensin 2 is being produced here. However, we will be inhibiting its binding to its receptor. If there is no binding class, if the receptors are not activated, that means there will be no constriction of the blood vessel. And sequel na yan ha, there will be no increase in the blood pressure. Okay? And then, aside from that, the release of aldosterone will also be regulated. There will be a decrease in the production of aldosterone, and that means mariregulate din natin yung sodium and water retention. Pag walang na-retain na sodium and water, that means there will be natriuresis that can also aid in the decrease or in the reduction of the blood pressure. Okay? So I hope by now, naintindihan nyo how these ACE inhibitors and ARBs help in the treatment of hypertension. So ano yung kinalaman nila sa hypertension? Ito yun. Their action will be on the kidneys through the renin, angiotensin, aldosterone system. Okay? Questions or clarification? Wala. Hintay bitaw ha, nakasabot ana. Sige. So I'm going to delete all the writings in the screen now. And let us move on. I will not be talking that much about aliskiren kasi it's not really that common in the community for the treatment of hypertension. We will be concentrating sa ACE inhibitors and sa ARBs. So what are the things that you need to know about our ACE inhibitors, those that end with prils? Most of the drugs are prodrugs except captopril. Captopril is an active drug. When you administer it, when you take captopril, it will automatically inhibit the ACE, the enzyme. Okay, magte-take na siya agad ng action. However, other ACE inhibitors are considered prodrugs, so definitely they are inactive. They have to be metabolized first before they can inhibit the enzyme ACE. Okay, so ano example nun? Example, enalapril. Enalapril is a prodrug. Inside the body, it will be metabolized to enalaprilat. Okay? Type ko na lang. So again, sample ng mga prodrugs natin, ng mga ACE inhibitors, we have enalapril. Inside the body, this will be, ay, ano nangyari dyan? This will be converted to its active form, and the active form is called enalaprilat. However, class, nowadays, they already have this enalaprilat, okay, in the market. So, synthesize na nila itong enalaprilat na ito, and meron na tayong talagang isang processed drug. I don't know if it's a tablet or a capsule, but enalaprilat na talaga siya. So, pag i-take siya ng patient, automatic na siya. Active form na siya. Pero kung enalapril ang tinitake ng patient, i-metabolize niya muna ito before it can take its pharmacologic action. So, another one, ramipril is another prodrug. And ano na siya, class? Palitan niyo lang yung ending. I mean, not really palitan, but dagdagan niyo ng 80. That's the active form of the drug. So like ramipril will become ramiprila. Okay? So ganyan yung mga names nila when they are metabolized and activated. Enalapril to enalaprilat, ramipril to ramiprilat. Kinapril to kinaprilat. Ganun yung mga names nila. But do not forget ha, most of our ACE inhibitors are prodrugs except captopril. Okay? Now, what's the advantage of taking ACE inhibitors aside from being a drug, syempre, for hypertension? This one has the ability to treat patients with conditions, chronic kidney disease, CKD. Okay? Pwede din siyang sa mga patient na merong CKD. Pag iti-take siya ng patient kasi with CKD, it can help in diminishing the proteinuria. When you say proteinuria, it's the presence of proteins in the urine. That is very common if a person has a problem sa kidneys niya and can stabilize renal function. So ACE inhibitors class have kidney protecting ability. Okay, and that is the reason also that ACE inhibitors are given to patients patients with diabetes, even if that patient class don't have hypertension o wala siyang problem in the heart. Kung meron lang talaga siyang diabetes, huwag kayong magtaka class ha if you encounter patient na diabetic siya, wala siyang hypertension, wala siyang heart condition, pero binibigyan ng ACE inhibitor. Ano yung reason doon? Yung rationale of using ACE inhibitors to these patients. That is because of the kidney protecting ability of our ACE inhibitor. So nasabi kanina that ACE inhibitors can stabilize renal function. That's the advantage of this drug. So, di ba, our problem with diabetes, due to the presence of excessive sugar in the blood, the kidneys are at risk. So, protect natin siya. Kaya binibigay siya sa diabetic patient even in the absence of hypertension. Okay? And syempre, this is useful in cardiac failure. Kasi for patients with heart failure, we don't want to have a lot of water and sodium in the body. That will cause hypervolemia, and that will not be a good thing for the heart. Mahina na nga yung heart and marami ka pang water, magtatrabaho pa siya na magtatrabaho, magiging mabilis yung progression ng heart failure ng patient kapag kaganon. So inhibit natin using ACE inhibitors, yung pag-increase ng aldosterone para ma-excrete yung too much water and sodium in the body. Now, what is the problem of taking ACE inhibitors? Yung ACE inhibitors kasi class is related to bradykinin. Kapag i-inhibit kasi yung enzyme na angiotensin converting enzyme, magkakaroon siya ng action in the also in the bronchioles, okay? And that will lead to the production of a lot of bradykinin, and this bradykinin kasi class can cause bronchoconstriction. So ang patient makaka-experience ng dry cough. Dry cough walang plema, walang phlegm. So, minsan, hindi na matotolerate ng patient yung dry cough niya. Masyadong mahirapan na siya maghinga sa grabing ubo. Pero dry, walang production of phlegm. So, yun yung pinaka-problema ng ating ACE inhibitors aside from angioedema. Angioedema is from the word edema, there will be like accumulation of water pero sa skin. Okay, so it's like a condition sa skin na magkakaroon ng mga blisters ganon with water. Pero yung pinaka-problem talaga, the dry cough. Okay, and aside from that, nasabi ko to last time that ACE inhibitors are contraindicated to pregnant women because they are considered teratogenic. Okay, they are considered teratogenic. They can cause deformities sa fetus, okay, sa unborn child. So be careful with that. Now, hindi ko siya nilagay dito, pero ganito. If the patient cannot tolerate the dry cough anymore, that's the time the doctor will have a change in the medication of the patient. Ito yung time class na papalitan yung drug, mag-shift to ACE, ARBs, angiotensin receptor blockers. Okay? So, again, ACE inhibitors muna kasi nga yung kanyang advantage of having the renal protection, mag-ACE inhibitor muna, pero pag hindi na matolerate ng patient yung dry cough, mag-shift na siya sa ARBs, okay, sa mga sartans. Yan yung time na gagamitin na natin si sartans. Si sartans, mga ARBs natin can also cause angioedema. They are also contraindicated to pregnant women, but yung advantage nila is walang dry cough. Okay, hindi sila nagko-cause ng dry cough. Okay, pero nowadays, parang mas ginagamit ata ang ARBs ngayon kasi sa mga prills. Nagdadiretso na ata yung mga doctor's class sa paggamit ng mga ARBs para hindi na mag-suffer ang patient sa dry cough. Pero sana yon? Reels muna sana yon para sa protection sa kidneys, especially for patients with diabetes and for patients with problems sa kidneys like the CKD, chronic kidney disease. Okay? Any question? So that's the end of this slide. I'm done with the antihypertensive agents. If you want to ask something, you may raise your questions now para ma-answer na natin. We will have our quiz on Wednesday. That will be a face-to-face quiz. And